My goal this morning is to talk to you about the metaphyseal cones. It's really not just filling the defects. In disclosure, I am a designer and a consultant for Zimmer Biomet. We'll be talking about the trabecular metal cones that we've designed. About 20 years ago, we came up with a model for managing bone defects using the Anderson classification. Simple defects dealt with cement morselized bone graft or small modular augments. Type 2 defects, a little bit more complex with structural allografts and modular augments. And then the type 3 defects with the structural allografts, even some of the larger cones and segmental prosthesis. I think what's important in revision arthroplasty is identifying the bone defects and how do you fill them and achieve adequate fixation. So as you have an implant that fails with significant bone loss, you need to achieve adequate fixation both in the metaphysis and diaphysis. Less fixation with poor metaphyseal fixation and only diaphyseal fixation is inadequate and will lead to failure. And how do we know this? Several years ago, we did a radiographic review of our revision cases performed by myself. And we identified 8 re-revisions that were sent to us, and over 60% of them failed due to poor metaphyseal fixation. These knees did collapse, into varus, especially on the femoral and tibial side. And those knees that were at risk were those that had undersized stems that were not canal fitting or diaphyseal engaging, and they used cement alone for augmentation. So it came to our attention about a decade ago that it's important to achieve appropriate fixation, and these type 2 and type 3 defects are very, very challenging, and they do have compromised metaphyseal bone. Realize that when you use augmentation to the femoral and tibial components, this is to help you position the components. It's not always giving you fixation to the residual bone. Modular augments are readily used, but what you need to achieve enhanced fixation and appropriate fixation is metaphyseal cones, and then the use of either diaphyseal engaging stems, or some choose to use cemented stems. But again, a lot of attention towards the metaphysis to get appropriate fixation. And this brings us to the concept of zonal fixation in revision knee, and I've really become an advocate of this over the last several years. Realize that you have the joint surface, which many times is compromised, but the metaphysis as well as the diaphysis are important regions of the bone that need to be well fixed. And you need at least 2 zones of fixation to get appropriate fixation, appropriate stability of that knee, both on the femoral and tibial side. If you look at this animation, this helps drive home that point. So even if you have a diaphyseal engaging stem with poor metaphyseal fixation, it was not uncommon to see tip of stem pain or hypertrophy of the bone. With good metaphyseal fixation with the use of cones or sleeves, again, this gives you 2 zones of fixation, both in the metaphysis and diaphysis. And since we've gone to metaphyseal fixation, we've seen less hypertrophy of the diaphyseal bone as well as less tip of stem pain. Trabecular metal has been a material that we've used for our trabecular metal cones. It has a porosity very similar to trabecular bone, and we've seen, adequate bone ingrowth that was very consistent throughout all the studies. If we look at the clinical results, in the past and the early results with the tibial cones, Mike Meneghini reported on the Mayo Clinic experience. I reported on our own experience. Again, we had stable osseous integration and good metaphyseal fixation in these cases without any evidence of loosening. Again, from the Mayo Clinic, looking at the femoral cones, again, well integrated without any complications, good stable fixation. The longer-term study with the femoral cones, again, from the Mayo Clinic, shows very reliable and durable metaphyseal fixation, an excellent survivorship, out there for over 96% for loosening. So good, stable fixation. While many of these early reports were from design surgeons, we've also had reports from non-design surgeons. Again, reporting that the use of the metaphyseal cones are a replacement for structural allografts with very effective biologic fixation and osseous integration. There has now been an evolution of the shapes and sizes as well as improved instrumentation. The new shapes and sizes of the femoral cones are more anatomically shaped to better fit the metaphysis, and again, using trabecular metal has very predictable osseous integration. Looking at the surgical technique, we've tried to simplify this using a drill and broach technique over the intermedullary reamers. So once you decide what your diaphyseal fixation and alignment would be, you check on, this is on the tibial side, where the defect is, you drill, and again, it's a calibrated drill to get you to the full depth of the cone. Following the drilling, you then select your broaches. I like to start with the smallest broach possible and then incrementally increase to fill that metaphyseal defect. Again, the beauty of the system is that it's over the stem extension, so you know exactly what the position of the diaphysis and the metaphysis is as you prepare the proximal bone. As you use the broach system, starting with the smallest one, you can incrementally increase to the larger one until you completely fill that defect. In order to fill that defect, the broaches will increase, but this will give you good stable fixation, very predictable as you move along in the procedure. It becomes very intuitive and very simple to prepare the metaphysis. So once you broach it, you can trial it, and then you put your final cone in place. This achieves your metaphyseal fill as well as your metaphyseal fixation. On the femoral side, again, it's very similar. It's, again, a drill and broach technique. Again, once you set your diaphyseal stem, you will drill to the appropriate depth, for the cone, and then broach incrementally. This also is calibrated so that you can address any augmentation that's needed on the distal femur, either on the lateral or medial side. Again, over the stem extension, so again, you know exactly the relationship of the diaphysis to the metaphysis to get you your 2 zones of fixation. You can also trial on the femoral side your metaphyseal cone, especially with the larger diaphyseal stems, and this will help you achieve the appropriate position, alignment, and fixation of your final component. So everything has been done during the provisional stages. Here you can see a case with significant bone loss both on the distal femur and the proximal tibia. The cones are in place, and you can see the ultimate outcome with the prosthesis, diaphyseal engaging stems, as well as metaphyseal fixation. So just 2 illustrative cases as I close. You can see here a knee that's failed into varus with significant bone loss. And in this particular case, we use augmentation to restore the mechanical alignment, and then metaphyseal fixation with cones and a diaphyseal engaging stem. To stress the point of poor fixation, this was a case that referred to me after 5 revisions. The patient continued to have tibial pain. You can see that he has a well-engaged diaphyseal stem, but still significant bone loss on the proximal tibia. And in this case, there was poor fixation in the metaphysis. Upon component removal, you can see the severity of the defect, the provisional component showing the augmentation, but the utility of cones both on the femoral and tibial side. You can see achieving the metaphyseal fixation with the cone and positioning of the implant with the augmentation. So in conclusion, what I like to stress is the metaphyseal fill and fixation. It's very important that you follow the 3 zones of fixation, and you need to get secure fixation with at least 2 zones. This includes the diaphysis with your stem extensions, whether you have long press fit diaphyseal press fit stems or a cemented stem. And again, what's most important is metaphyseal fixation with the cones. Again, many times that bone is deficient, and the cones will help both fill and fix your implant. Thank you for your attention.